Hi, this is Sherry Shabowski, and thank you for returning for medical decision making. Today, we're going to focus on risk assessment. I call risk assessment an evaluation of the patient's protoplasm. Someone once told me, is protoplasm is the stuff with which all cells are made. I'm extrapolating that here. And what I'm going to call protoplasm is everything that makes your patient different from a perfectly healthy person of the same age. Medical problems and medications feels like a no-brainer as far as risk assessment goes. I mean, if they have the disease or they're taking specific medications, that will definitely predispose them to different illnesses now. For instance, Hib-Haya. The Hib-Haya phenomenon is had it before, had it again. This is the single greatest risk factor for any disease. If the patient had it before, clearly they're at risk to have it again, unless whatever the problem was physically removed. Now we'll move on to social history, which will include all the personal choices and the resultant exposures. This becomes more and more important as patients age. It includes things like dietary indiscretion, smoking, vaping, alcohol use, drug use, and remember, when it comes to drug use, route matters. Then we move on to family history. Family history, especially something that's very prevalent in the family, really matters. Like if everyone has colon cancer, or if someone tells you that everyone in my family had a heart attack by the time they were my age. You better stop right there and seriously consider that they might be having a heart attack. This is pretty powerful stuff if it's prevalent in the family. When you go further with family history, the next people you're going to think about most is what happened to the person's brothers and sisters. I mean, because they're really the closest genetically, right? Parents come next. They are important. You're half of each of them. Grandparents, sure, they matter, not as much. And if one person has a disease in a big family, does that really implicate the risk for your patient? A little. Then you get to the second cousin of the grandmother and, oh, just quit. If something is that irrelevant, you can just move on. Then I have allergies in here because allergies are very important throughout the medical evaluation. If a patient is allergic to latex, for instance, they're going to be exposed to latex potentially the moment they walk in. So you're going to want to know that right away. You want to pick the right gloves, right? Also, anytime you're going to give a patient medication or do any kind of diagnostic intervention, there's always a risk that the patient could be allergic. So knowing that information up front is really important for risk stratification. Here we have the reminder that the most important risk factor for any disease is had it before, had it again phenomenon. If they've had the disease before and whatever the offending agent is was not completely removed, they are at risk for having it again. This is the greatest risk factor for any disease. For instance, people who have one clinical manifestation, let's say of atherosclerosis, frequently have two. So if you knew that your patient had had a stroke in the past, you would then know that they are at risk for other diseases that are associated with atherosclerosis, like renal failure, coronary artery disease, or claudication. It is a systemic disease after all. So if someone has one proven disease, another disease with the same etiology will have more weight in the differential. That's not the Hib-Haya, but you can see how this plays into risk stratification, and you might not have thought about it before. Let's go a layer lower. Now, we were just talking about vasculopaths, who usually have diseases related to atherosclerosis. So, if you're wondering if someone is going to have, let's say, a stroke, typically caused by atherosclerosis, Then you're going to want to know if they have risk factors for atherosclerosis. For instance, smoking, diabetes, hypercholesterolemia, obesity, a sedentary lifestyle, and high blood pressure. Any one of these things is not going to have a strong association with a stroke, but they definitely play in. Let's talk about smoking. Smoking is a risk factor for almost every cancer and strangely makes ulcerative colitis better. That is a strange fact. When you find out that the patient smokes, might want to dive a little deeper because the greater the exposure, the more likely they're going to suffer a consequence of the choice. So you need to know how much they smoke, for how long. Less is going to be better in general. But cancer also comes on without an obvious trigger, so it is no guarantee that the patient will have cancer, obviously. But it does make it a little bit more likely, so risk stratification is met. Here's just a slide to remind you of the weighted risk factors that help you to stratify. First, the HIB-HIA, the highest risk factor of them all. Then there's a similar disease with the same pathophysiology as a proven disease. That would have been the vascular path example. Very strong family history, meaning that multiple people in your family have the same disease. Something's going on in those genetics that's putting that person at more risk. Then the general family history does play a role, especially if it's first degree relatives or people who are genetically very similar to you. They also usually live in the same house and are exposed to the same things. This also puts you at similar risk for other things. Finally, there's the social history. It is well worth getting to know your patient and their activities of daily living because then you have a sense of how to stratify for diseases in general. All right, that's where we're going to end for today. I'll see you next time.